And welcome to my video channel. My name is Dimitri Hristev and I work in Plovdiv, Bulgaria as a physiotherapist. In my clinical practice I mostly help people who recover from stroke or other trauma to the nervous system. In today's video I want to talk more about the passive movements and why do I use them in my clinical practice. When we talk about the passive movements, we have to recognize that they don't have the same value as the active movements. Why is that? Because when we move passively some joint, we are basically moving the bone, we are moving the tendon, but the muscle is not helping. That means that the tendon is not moving physiologically. When you have active movement, the muscle is pulling on the tendon, which of course is also pulling the bone and is creating normal and physiological forces on the tissues of the extremity. Passive movement cannot create the same physiological loading, but it's a good option when the patient cannot do anything. When do I use passive movement? I use it in the early stages after the stroke, when the patient is not responsive, when the patient cannot control his limbs, then I use passive movements. Why do I use them? Because I need to do to maintain some healthy range of motion. But I use the passive movements with caution, especially when I have to move the shoulder. The shoulder joint is a very unique joint. It's not very stable, but it has a huge range of motion. So when stroke happens, the muscles which are giving the shoulder joint stability, they're basically beginning to waste. They're getting weak, they're losing their volume, and the muscle and the joint itself is getting more unstable. Then I'm very careful when I have to move the shoulder joint. I don't try to reach the full range of motion. Usually I would go to 90 degrees. I wouldn't try to get full range of motion in external rotation because the shoulder joint is very gentle in this stage, and if I'm not careful when I'm moving the joint, I could create some instability. I could injure the tissues of the rotator cuff, and this could lead to pain later on. So when we're talking about the shoulder joint, the movements, the passive movements should be very gentle and not in the full range of motion. The elbow, it's a more robust joint, so I would try to get a good full range of motion, but I would be more gentle when I'm trying to reach the end range of motion in supination. Usually the pattern in which the arm stays after stroke is in this position because of spasticity and the stiffness which occurs because of the lack of normal active movements. So I would try to reach full range of motion, but I would be more gentle when I'm supinating the arm. When I'm passively moving the wrist, I would try to get as much range as the joint allows without pain. The wrist is a joint which is stable, but it swells very easily, and it's also painful. So I wouldn't be very aggressive with it. I would try to maintain some functional extension, which is about 30 degrees. With 30 degrees we can reach, we can grab, and this is functional. I wouldn't go full range of motion, especially if there is some stiffness, some swelling, and spasticity. I would, when there is some swelling, I would advise the patient to keep the arm above the level of the heart. I would advise using some compression garments and other interventions, which maybe I will describe them in another video. But the wrist 30 degrees is, in my opinion, is more than enough. So in the early stages, when the wrist is plegic, yes, maybe try to maintain full range of motion, but I would go gently, because I don't want to harm the wrist. And in case if there is any swelling after the therapy, I would decrease the amount of the passive movement. Maybe I will decrease the volume of the movements or the range. It depends. It's always individual. Every patient is different, and his or her case needs individual approach. The fingers are also very gentle joints, and they also very easily get swollen. So I would try to maintain a healthy range when I move them passively, but I wouldn't go too aggressive on them. With the leg and with the foot, the story is the same. Hip joint, yes, it's a stable joint, not so painful, but it could get painful in the end range of motion. So be gentle with it. The knee is a very stable joint. You can try to maintain good flexion, but be more careful with the extension. Usually when we treat someone with stroke, we expect the knee to go in hyperextension because of the weakness in the muscles of the knee. So I would try to maintain a good flexion and some normal extension, but I wouldn't pull the knee in hyperextension. When we talk about the ankle joint, the dorsal flexion is something that we easily lose, so I would put my efforts in that area. But of course, moving passively the joint with your with my hands cannot give good results. So I would try to find good exercises and good functional activities which would load the ankle joint more functionally. But passive movements are good to maintain some good range of motion and joint health. Unfortunately, they are not better than, not unfortunately actually, they're just not better than the active movements. You cannot teach someone something just with passive movements. Yes, you can use passive movements to show some activity, to show some movement, and later on to try to facilitate that with maybe some small assistance until the patient achieve the activity actively. But just with passive movements we cannot change the neuroplasticity in the brain. So the passive movements shouldn't be the focus of the program. When we have some active movement, that should be our focus. Moving actively is always better. When what do I think about continuous passive movements? There are some machines, there are some robots that can provide the extremity with passive movement. Well, I'm not sure that I would use them very extensively. Maybe in combination with mirror therapy, yes, but just passive movements without any thought, no. Maybe some virtual reality also. You know, there are some advances in technology, and especially in the Western countries. Here in Bulgaria we cannot, we don't have them, but if I have to move someone passively for a long time, I would try to combine this with mirror therapy, and I would try to engage the attention of my patient in this activity. When else we can use passive movement? When we use dynamic sprints. In dynamic sprinting we have active flexion but passive extension. So learning to relax, learning to let the dynamic sprint extend the fingers, it's good, it's passive movement. In time we hope that this passive movement can become active. So I think this is more than enough information in this area. I hope you find this video useful, even though my English is not perfect, and I hope that you would subscribe to my video channel. In case you have any questions, write them in the comment section. Take care.